All right, let's dive into heart failure. It's one of those syndromes that, let's be honest, can feel a little overwhelming at first. But if you're a medical trainee, mastering this is absolutely essential. You're going to see this a lot. So today, we're going to break it all down and give you a really solid framework so you can walk onto the wards feeling confident.
So what's on the docket? First, we'll nail down what heart failure actually is. Then, we'll get into how you diagnose it. After that, the really good stuff, the life-saving treatments for HFER. We'll also touch on HFpEF and some device therapies. And finally, we'll wrap up with how to manage these patients for the long haul.
Okay, first things first. Let's build our foundation. Before we can even think about treating this thing, we've got to be on the same page about what it is. So, here's the absolute key takeaway right off the bat. Heart failure isn't a single disease. It's a syndrome. And what that means is it's the final common pathway for a bunch of different problems. At its core, it boils down to one of two things. Either the heart has trouble squeezing blood out, that's a systolic problem, or it has trouble relaxing to let blood in. That's a diastolic problem. And that right there leads to probably the single most important question you'll ask yourself when you meet a new patient. Is this a pumping problem or a filling problem? In other words, is the heart muscle too weak to pump, or is it too stiff to fill up properly in the first place? Everything else we do flows from this one distinction. Okay, so how do we actually put a number on this? Well, it all comes down to the LVEF, the left ventricular ejection fraction. Think of it as the percentage of blood that gets pumped out with each beat. If that number is 40% or less, we call it HFrEF, heart failure with reduced ejection fraction. That's our classic weak pump. If it's 50% or more, that's HFpEF, heart failure with preserved ejection fraction. That's our stiff pump. And yeah, there's that little gray zone in the middle, HMEF, but honestly, that LVEF number is going to be your North Star for treatment. All right, definitions are down. Now let's get practical. How do you actually spot heart failure when a patient walks through the door? It all starts with your clinical suspicion, right? You're looking for that classic story of volume overload. The patient tells you they're short of breath, especially when they lie down at night. Their legs are swollen. Then you do your exam and you see that their neck veins are bulging, or you listen to their heart and hear that classic lub-dub-dub sound, that S3 gallop. That's when the alarm bells should be going off. But wait a second. Lots of things cause shortness of breath, right? Pneumonia, COPD. So how do you know for sure that it's the heart and not the lungs? Well, your best friend in this situation is a simple blood test, the BNP, or B-type natriuretic peptide. Your heart releases this hormone when it's under stress and stretch. So if the level is really low, heart failure is pretty much off the table. But if it's high, say over 400 like you see here, then heart failure becomes super likely. It's an amazing tool for differentiating what's going on. But to seal the deal, you need an echocardiogram. This is the gold standard. The echo doesn't just confirm the diagnosis, it's going to give you that all-important LVEF number we talked about, so you can classify the type of heart failure. Plus, it can give you major clues about what caused it in the first place. Okay, let's shift gears. We're now getting to what is arguably the most important, highest-yield part of this entire discussion, especially for trainees. We're talking about the medications for HFrEF, the weak pump kind, that have literally changed the game. This quote right here, straight from the guidelines, really lays it all out. Today, we don't just have one or two drugs. We have a foundational therapy built on four, count 'em, four key drug classes. And if you're taking care of these patients, you have to know these cold. So here it is, your cheat sheet. These are the four pillars of what we call guideline-directed medical therapy, or GDMT. You've got your RAS inhibitors, beta blockers, MRAs, and the newest kids on the block, the SGLT2 inhibitors. The amazing thing is that they all work in different ways to stop the vicious cycle of heart failure. Beta blockers, for example, they shield the heart from the toxic effects of too much adrenaline, which can actually help the heart muscle heal a bit, a process we call reverse remodeling. And the goal, let me be clear, is to get every single HFrEF patient who can tolerate them on all four of these pillars. That's the standard of care. Now here is a huge clinical pearl. You know, the old school way of thinking was start one drug, max it out, then start the next one. We don't do that anymore. The modern approach is all about speed. We start low doses of all four pillars either together or in quick succession. The idea is to get that four-way protective shield up and running as fast as humanly possible. Okay, so HFrEF has this amazing four-pillar foundation. But what about the other half of our patients? The ones with HFpEF, that stiff pump problem. And what happens when the pills aren't enough?
For the longest time, the difference in how we treated these two was like night and day. With HFrEF, we had all these amazing drugs that actually reduce mortality because they target the specific hormonal pathways that make the heart weaker. But with HFpEF, it's a different beast. The causes are more varied. So the focus was really just on symptom control, using diuretics to get fluid off, and then just going after all the other problems, like high blood pressure. But, and this is a big but, the story for HFpEF is finally starting to change. This is super exciting. It turns out that SGLT2 inhibitors, one of our big four from the HFrEF world, have been shown to reduce hospitalizations in HFpEF patients too. And MRAs are also an option for some. We're not quite at a mortality benefit yet, but that gap between the two types of heart failure is definitely shrinking.
But what if you've got your patient on all the right meds and they're still really sick or at high risk? Well, that's when we start thinking about hardware. We start thinking about devices.
So here's a quick and dirty algorithm for how to think about this in HFrEF. Step 1, and this is non-negotiable. You have to give the medicines a chance to work. We're talking at least 3 months on the best medical therapy they can tolerate. Step 2, if after those 3 months, their ejection fraction is still 35% or lower, you've got to protect them from life-threatening arrhythmias. That's where an ICD, an implantable defibrillator, comes in. It's like having a paramedic sitting inside your chest. Then, step 3, if that same patient also has a very wide QRS on their EKG, which means the two sides of their heart are beating out of sync, we can consider CRT. That's a special kind of pacemaker that helps resynchronize the heartbeat, which can make them feel a whole lot better.
Look, getting the diagnosis and starting the meds is a huge part of the battle, but it's really only the beginning. Heart failure is a chronic, long-term marathon, not a sprint. And success really depends on building a partnership with your patient.
If there is one number I want you to burn into your brain from this whole explainer, it's this one: 7. Getting your patient a follow-up appointment within 7 days of leaving the hospital, it's one of the most powerful things we can do to keep them from bouncing right back in.
And it's the little things, the day-to-day stuff that really add up. You have to teach your patients to weigh themselves every single morning. That's their early warning system for fluid buildup. You also have to warn them, and this is huge, to stay away from NSAIDs, ibuprofen, naproxen, because those can wreak havoc by making them retain salt and water. And of course, you got to be relentless about managing their other problems, like diabetes and high blood pressure, and get them into cardiac rehab. It's all about empowering them to manage their own condition. And this chart, this really drives home why all that matters so much. Look at this. Getting admitted to the hospital for heart failure isn't just a bump in the road. It's a major, major turning point in their illness. The risk of dying in the next year jumps to around 20%. That's just staggering. It really tells you how serious this is and why keeping people out of the hospital is priority number 1.
So let's end with this. For so long, the name of the game in heart failure was just trying to slow it down, to manage the decline. But now, with these incredible 4-pillar therapies, we're starting to see something amazing. We're seeing patients whose heart function actually gets better. Sometimes it even returns to normal. So the big question for the future is this: can we move beyond just managing heart failure? Can we start talking about actually reversing it?